So good morning. Thank you for being here. Today's session is we're very excited. We have Dr. Basir here. Thank you, Babar, for being here. He's an interventional cardiologist and director of the STEMI program and acute mechanical circulatory support at Henry Ford Hospital in Detroit. He specializes in the treatment of complex coronary interventions, including PTO intervention and the use of advanced MCS support devices. He's also the chair of the SkyShock meeting that takes place annually. I think this year is in Washington, D.C. And most important, he's the co-investigator of the National Cardiogenic Shock Initiative that has been like a true inspiration for us here in Tech Salud in order to perform our own protocol based on the NCSI. Hopefully this national can grow into an international cardiogenic shock initiative with us. So thank you, Babar. Thank you for being here. We can start with your presentation.
Thank you so much for having me. Really appreciate it, and super excited to be here. I are able to see my screen now?
Yes.
Wonderful. So definitely SkyShock is happening in October of this year in DC. You know, our friends are definitely more than welcome. It should be a really fun meeting. We're also going to be coming down for the meeting in Mexico later this year as well. So hopefully that will be fun. And definitely we are very much looking forward to starting an international cardiogenic shock initiative. So let me start by talking a little bit about what I think about post-DanGer, what it means to be treated in, how do we best treat patients in cardiogenic shock, making sense of the trials that have been done, and, kind of discussing a little bit about how we move forward. And I'll leave plenty of time at the end, at least 20 minutes or so, for ongoing discussion for our group. These are my disclosures. So the objectives really are to summarize the DanGer shock trial, identify the major differences between the trials that have been done, talk about what the pillars of cardiogenic shock care and contemporary management are, and really how do you implement NCSI in your own institutions, and describe the importance of, how we, create a system of care, usually with a cardiogenic shock team, to be able to get very reproducible outcomes for our patients. So first and foremost, and I won't spend much time at all about background here because I know that this group is well versed in it, but really the main pathological problem in cardiogenic shock is decreased forward blood flow that causes end organ failure due to decreased perfusion. And I think it's really fundamentally important that that is the premise that we're talking about, because the use of hemodynamic support devices is really to help for that purpose. Maybe there's some other utilizations for it, other important findings. There may be a benefit of unloading, for example. There's definitely some benefit of coronary perfusion, these kinds of things. But really the crux of why we use it in shock is to get end organ flow. And when we don't get end organ flow, or we have hypoperfusion, for every end organ that's involved, you have worsening outcomes. So you have worse outcomes when you have pulmonary edema. That's what we're typically starting with. But then you develop shock liver, acute kidney injury, God forbid, anoxic brain injury. Clearly, the mortality is increasing with each of those end organs involved. And so the primary purpose of these devices, and I'm going to spend a lot of time talking about Impella and ECMO in particular, is to improve those hemodynamics. And particularly in AMI, the left ventricle is stunned. We use inotropes and vasopressors, but at the end of the day, they have a cost. And that cost is that they increase myocardial oxygen demand. And we think of them as being benign, that they're just medications that we have to use. And to a certain extent, all of that is true. But to use them as the sole therapy, particularly at higher stages of cardiogenic shock, is likely really, really problematic. And before DanGer, it is important to remember that these devices were approved, at least in the United States, because of changes in hemodynamics. And those are meaningful changes. And that was the basis of approval. And now with DanGer Shock, we have a trial that proves that it saves lives as well. So here's what DanGer Shock included. It included only patients with STEMI, not NSTEMI. It included patients that had both hypotension and hypoperfusion, systolic blood pressure less than 100, and hypoperfusion was a lactate greater than 2. The EF had to be assessed with a POCUS, and the EF needed to be less than 45%. This is the first trial that I'm aware of that included that. And randomization started when the shock was diagnosed. So in the event that you presented with a STEMI, you didn't have shock on presentation, and then you developed shock either in the procedure or after the procedure up to 12 hours, you were essentially allowed to be within the trial as well. The major and very important exclusion criteria are that they excluded patients who had comatose out-of-hospital cardiac arrest, patients with right ventricular failure, and then patients with mechanical complications. But really, the first exclusion here deserves a little bit of our attention, right? Because this is the first trial that essentially excluded these patients. When you look at the shock trial and the ECLS shock trial, they did not exclude this cardiac arrest patient population. And we'll talk a little bit more about it. Now, it is important to know that in DanGer, they did include in-hospital cardiac arrest. They also included cardiac arrest in the EMS system. So if it was witnessed in out-of-hospital cardiac arrest by EMS, it was still included. So there was still a fair amount of cardiac arrest in the trial, and I'll share with that a little bit later as well. They included 355 patients. Their median age was 67 years old. 79% of patients were male. The median from STEMI symptoms to randomization was about 4 hours, and 84% of patients were randomized within the cath lab. The median lactate level was 4.5. The median EF was around 25%. Median systolic blood pressure was 82 millimeters of mercury. The vast majority of the time, over 2/3 of patients had an LAD or left main culprit, and similarly had multivessel disease. Now, the SKY shock stages were assigned to these patients retrospectively, and 55% were classified as stage C and 45% at stage D or E. And there's some nuance to this that we can discuss as well if needed. But most importantly, what the trial essentially demonstrated was that patients treated with Impella had actually a significant improvement in their survival to 180 days or 6 months. And it was a 12.7% absolute risk reduction in mortality, and the number needed to treat there was 8 patients. And so that is a really, really important trial. The first positive trial that we've had in cardiogenic shock since the original shock trial that was published in 1999. So we've gone, 2.5 decades before we've had this randomized trial. And then, there's a lot of things that we can discuss about the trial and some nuances, but I'll point out a few of those right now. The complication of these patients, though, was something that was important to consider. So you can see here that those patients that were treated in blue represent those who were treated with Impella. So there was a double rate of bleeding, of moderate to severe bleeding. Limb ischemia was at 5.6%. Renal replacement therapy was at 42%. And that it's important to kind of talk a little bit about this, because ultimately we found out from the investigators of the trial that at the 6-month mark, actually only 3 patients, I believe, were actually on dialysis. So this was mostly short-term renal replacement therapy, and we have to get a better idea of what the practice patterns were, within Europe at that time. And a little bit higher risk of stroke and sepsis as well. And some of these complications are just because these patients survived and were in the ICU for longer periods of time. And so those are important things to keep in mind as well. But the conclusion of the trial was that the routine use of Impella on top of standard of care reduced death from any cause in patients with STEMI and cardiogenic shock. It was associated with an increased risk of adverse events, but the study results and that the study results could not be extrapolated to other forms of cardiogenic shock. So the comatose patients, the NSTEMI, the non-ischemic cardiogenic shock patients. Now, I agree definitely with the non-ischemic shock patients. I think that's a really different subset of patients. I don't know if it really makes a whole lot of difference in the other two categories. I think when you use it in out-of-hospital cardiac arrest, you just know that there's a chance that your patient has an anoxic brain injury and your device won't help you. And then from an NSTEMI standpoint, I actually think that we have just enough data for NSTEMI as well, using the NCSI numbers that, I would personally treat patients with NSTEMI in a very similar fashion. But that was what the authors concluded and what was published in the New England Journal of Medicine. So what's really fantastic here is that now we can really take a step back and look at all of the important large randomized control trials that have been done to date. And I think for those of us who are interested in cardiogenic shock, those of us who are working to study this disease process more, it is really important because there's lots of nuances and differences here. And so when you look at DanGer, a couple of things, are really important. Firstly, their percent enrollment to screening was around 30%. So it was a selective patient population. And I would just have you look across the screen and look at the original shock trial, and you can see that the enrollment to screening ratio was around 20%. Very similar patients. So these were selected patients. When you look at the balloon pump shock trial, that included the most all-comer patients. The culprit shock trial included 63%. And the ECLS shock trial, which also had a lactate cutoff, was 48%. So really, it is a selective patient population. They were identified patients with predominantly hypoperfusion, not patients who had out-of-hospital cardiac arrest, and patients who had a lactate level greater than 2, so they were sicker patients. Now, it took them 10 years to do this trial, and why is that? Well, one is that they included a very small number of sites compared to the other trials that have been done. They only included 14 sites. Actually, originally, they only started with the sites in Denmark and then expanded to Germany and one site within the UK as well. The shock definition was very similar, but it did include the lactate level. And the most important aspect is, if you can look at the last line here, the cardiac arrest rate. So it included 20% of patients who had cardiac arrest. Out-of-hospital cardiac arrest was allowed if the patient was neurologically intact prior to their presentation. But it's very different than, for example, the ECLS shock trial, which included 78% of patients who had cardiac arrest, and ROS was allowed for up to 45 minutes. And so this cardiac arrest business in shock trials is something that's really, really important to consider. And now I added in red here what we had in the shock initiative. And the reason that I add this in is because it really mimics DanGer shock very well. We had 406 patients. The enrollment to screening rate was around 34%. It was a selective cohort. Because we had 80 sites, we were able to get the data within 4 years. Very similar inclusion and exclusion criteria, but we included NSTEMI. And you can see that our out-of-hospital cardiac arrest rate was 46%, and ROS was less than 30%. But we also excluded patients who had signs of brain injury upon presentation. Now, the brain injury was not just that they were kind of comatose, but that they had other concerning neurological findings. And so it is important, I think, to keep this in mind, because in NCSI, we got relatively good outcomes despite including these patients as well. And I think what all of this does is it puts ECLS shock trial into perspective a lot more, right? So 95% of these patients had altered mental status, 77% required resuscitation, 45% had targeted temperature management. The median lactate level was 7%. And I think it is important also just to point out a few really important things about the trial. One was that only 20% received ECMO prior to PCI, despite this being the recommendation of the trial. And I have to question whether the systems were in place that allowed for easy ECMO use within the cath lab. And I'll talk about it a little bit at the end of our presentation, how we do it at Henry Ford, but it is really important to keep in mind. If you're not going to be able to implant ECMO quickly, it becomes a big problem for these patients. And at least in the United States, that's an issue. I'm hopeful that in your institutions in Mexico, that is a little bit quicker and not as political of a process. The other thing is that the vast majority of these patients did not get advanced heart failure therapies. And at least in the United States, when we use ECMO, we really do spend a lot of time thinking about what the exit strategy for these patients are and whether they're candidates for these advanced heart failure therapies. And so because of the increased afterload within the ECMO, they had to use more dobutamine in the ECMO arm. But overall, the most important message is that no subgroup benefited. And I think it's really important to keep this in mind because at least in where we practice, ECMO is not a device that we go to unless absolutely necessary. And it's typically in the setting of escalation, not as the first line therapy outside of cardiac arrest patients. And so it becomes really important to kind of keep these subtleties in mind. So I thought I would spend at least a little bit of time talking about this difference between when we include cardiac arrest and when we exclude cardiac arrest, because it's natural to think that because we're including cardiac arrest, that those patients are automatically sicker patients. And I would personally think this early in my career as well. But I think that, we have to actually think about it a little bit differently. So firstly, there's right? So 50% of patients with AMI cardiogenic shock experience a cardiac arrest, and two-thirds of patients who have some form of cardiac arrest also have shock, meaning that they require vasopressors. But it is very different on how we categorize these patients. Somebody has an out-of-hospital cardiac arrest, they're down for 15 minutes, they are on 5 mics of norepinephrine, and their lactate level is 8. Well, their lactate level is 8 because of the arrest time, right? They were in a state of complete hypoperfusion. But now that you've restored their rhythm, that lactate level should clear. They hopefully will not stay and persist in cardiogenic shock. But we don't wait for that to happen, right? We have to treat patients right away. When patients don't have cardiac arrest and they have a lactate level of 4 or 5 or higher, those patients have been hypoperfused for a long period of time potentially. So that's why they tend to actually be sicker. So if you look at the left-hand side of your screen, this is a trial from Germany, which essentially showed that patients with shock who did not have out-of-hospital cardiac arrest had the highest mortality within the first 6 hours of their presentation. And this is very similar data to what you see on the right-hand side as well, where the red line represents patients who had primary cardiac failure, where they had hypoperfusion without the cardiac arrest feature. And you can see that what happens to these patients is that they die very fast and very quickly. And so the mortality, for example, at 50 hours for these patients is around 75%. And so it is really, really important to kind of keep that in mind because these differences are really important, not just in how we evaluate trials, but more importantly, also how we treat our patients when they present to themselves. So here's looking at a little bit of data from DanGer as well as data from NCSI to really help describe what kind of patients we're talking about. So the sample sizes are listed here. You can see that the ages are overall very similar. The amount of females included are generally very similar, particularly in STEMI shock. It is not 50-50. It's not that women present the same amount as men present, right? Women actually have less rates of STEMI shock as compared to men. And so that's why also their number is less within these trials. But high use of vasopressors and inotropes, high rates of cardiac arrest in general, high heart rates, low blood pressures, lactate levels that are very high but very similar. You can see that ECLS shock stands out as having the highest lactate level as 6.7. You can see that most of these trials included patients that had lactate levels greater than 2 or had a large proportion of these patients. But what you can see here is the standard of care arm versus the therapy arm was different, particularly within the shock trial and within the DanGer shock trial. But you can see that overall, the rates of survival are still relatively low. They hover around 50 to 60% based on those who are included in the trial. And those numbers, in fact, go down more when you look at the 6-month outcome of these trials. But what is really important to kind of keep in mind is that in DanGer, those who were treated at 6 months had the highest survival out of any of the other groups that have been studied so far. And it's very, very challenging to do cross comparisons amongst the trials, but it is important to realize that these patients really did have the best outcome that we've studied to date. It mimics actually the outcomes that we've seen in the cardiogenic shock initiative as well. So clearly, we really strongly believe that this data is extremely accurate. Now, when you look at complications, it's similarly important to look at the complication rate across these trials. And I was surprised when I looked at this. And remember, the balloon pump shock trial was done over a decade ago, but you can see here that the bleeding rates within the standard of care arm in the balloon pump or those who were treated with a balloon pump in the balloon pump shock trial was 20%. So these patients bleed. Why? Because they had STEMI, they're in shock, they have liver failure, they're giving heparin for MCS devices potentially, they're already on dual antiplatelet therapy because of their stents. And so these patients bleed a lot. So in the shock trial, the bleeding rate was around 28%. In the balloon pump shock trial, it was around 20%. And then in ECLS shock trial, when you used ECMO, it was around 23%. And in Impella, in the DanGer, it was around 21%, and very similar numbers within NCSI. What's really important here as well is just to kind of point out that bleeding is something that we're never going to get rid of, but I think with really important, best practices using micropuncture, ultrasound, single stick, mid-femoral head access, peeling away the sheath, pre-per closing the impella so that you can use the per closes to cinch the arteriotomy if needed. Those are all really important aspects of bleeding. And the other thing is that bleeding is not just site bleeding, right? These are sick patients, they have GI bleeds, they have hemolysis from the pumps. That's a really common reason of the bleeding as well. The other important thing to point out here is the rate of renal replacement therapy. And what really stands out is DanGer shock, right? 41% of renal replacement therapy, higher than any of the other trials that have been done to date. And there's two probably reasons for this, right? One is that, again, they were hypoperfused patients, so they had more acute kidney injury than the prior trials, which included more cardiac arrest patients. And the other thing is that by protocol, the Impella was used at P level 8 for the first 24 to 48 hours. And not on auto, which is what we typically use. So I think that there's some concern here that hemolysis also had a part to play with that. And hopefully with better recognition in terms of placement, using the auto feature within the Impella, and then identifying RV failure, which can complicate and cause diastolic suction alarms, those are also really important things to actually decrease the rate of hemolysis. So what controversies came out after DanGer? So the first controversy was, should we actually treat patients with women, in shock? And absolutely we should, right? So if you look at the shock trial, women did not get as much benefit from revascularization in the subgroup analysis. Why? Because there was less women included in the trial. It was, again, only about 20% of women included in the trial. Culprit shock included a slightly higher proportion of women, but again, no difference in culprit-only PCI in terms of women being treated. And similarly, in DanGer here, women had, the confidence interval crossed 1, but again, this is a subgroup of underrepresented group within these trials. Women were less than 30% in all of the trials that have been done to date. And that's the reason that there's no real major differences. I think if you can put the device in a woman, we know from other observational studies that women get just as much, if not even a more of a hemodynamic effect with these devices. And I think it's really important to kind of keep that in mind. Now, the other question is, should we do another randomized control trial, right? Lots of discussions from the academic folks here that the p-value was only 0.04. And would you do another trial? So one thing that you should know about me is I'm a real doctor, right? I spend 80% of my time doing clinical work, and I'm not somebody who's ever been in the ivory tower, right? I want to be extremely practical. My goal is to help hospitals throughout the country and throughout the world really get better at doing procedures and trying to save patients' lives. And I'm not going to personally get bogged down a whole lot in this statistical values. I also think that it's really important, and data that we published in JACC Intervention in a couple of years ago, where it shows that this was before ECLS and DanGer, but that we don't actually do a good job in doing these trials. In fact, in the last 20 years, again, when the study was published, there was only 14 randomized controlled trials and 2,000 patients in trials, while the registries included, well over 100,000 patients. And so we're not actually including a lot of these patients. And the patients included are less likely to be women, less likely to have comorbidities, have better hemodynamics, and they get better care, and therefore they have better outcomes. And so the fact that DanGer is positive despite these issues is I think really, really important. And so I feel strongly, and I've been saying this for a few months, that we do not need to do another trial. And actually just yesterday they publicly announced that the Recover 4 trial, DSMB, actually halted the trial because of concerns that there was not equipoise in being able to randomize. Because now, on the heels of DanGer Shock, could you actually randomize patients to a non-Impella arm? I felt very strongly, as many others did, that you could not do that ethically. And so they actually stopped the trial as of yesterday officially. And so what DanGer actually represents is it represents a change. It's a guideline changing trial. When the shock trial came out, it changed the revascularization guidelines to a 1B. When culprit shock came out, culprit only PCI was recommended as a 1B recommendation. We don't know where DanGer is going to, end up, but it's a similar sample size to the original shock trial, right? It's a similar p-value here, 0.03 versus 0.04. And the number needed to treat is 8 to save one life. And so my personal feeling is that it should be a 1B recommendation. I'm not sure if politics will get in the way of that decision being made, or because of the complications that we're seeing, whether that's going to be something that causes it to be a 2A recommendation. But my personal belief is that it should be a 1B recommendation. And so it is really an important trial that we really need to kind of wrap our heads around. And what it represents is a historical advancement in the treatment of cardiogenic shock. We started with the ability to treat patients with lytics. Then we were able to basically treat patients with balloons and stents, and that improved our mortality to about 50%. And I think on the heels of DanGer, with the data that we have with NCSI, Impella should be the standard of care in AMI cardiogenic shock, and hopefully will continue to improve outcomes well above 75%. And so I wanted to take some time talking about NCSI, because I think what NCSI is it's actually a playbook for DanGer. DanGer is an ultimate trial, right? It was very hard to do, took 10 years to get to, and we're probably not going to get a replicating trial of it. But what NCSI represents is it represents how to do this practically. The early use of MCS, how to deliver it quickly, how to optimize the PCI, avoiding vasopressors and inotropes, creating a hub and spoke model to be able to get good outcomes for these patients. And so what it does is it creates a uniform protocol to get predictable outcomes in these patients. But it is important to know how to do this. So the first step in doing this is actually to create a system of care within your hospital, or to consider building a cardiogenic shock team. And this has been looked at by multiple different groups. And in observational studies, the use of a shock team was associated with better outcomes. Shock teams use more invasive hemodynamics to guide their decision making. They actually use slightly less advanced hemodynamic support devices, but when they use support devices, they use more robust support devices, and they are able to save more patients. And so I think it's an important first step in changing the culture of your institutions. And then there are really important aspects of NCSI that are fundamental to getting better outcomes. Number one is decreasing the delay of care, right? You want to identify these patients as early as possible, treat them as early as possible. This has been shown by the ANOVA group. It's been shown in NCSI that treating patients quicker, not relying on vasopressors and inotropes alone in these sick patients is critically important to getting good outcomes. Differentiating STEMI shock from non-STEMI shock, or actually I should say AMI shock from heart failure shock, is something that's really important, right? It was something that we emphasized in the shock initiative. We really created a AMI shock protocol, but our friends in the cardiogenic shock working group have done tremendous amount of work, probably more than any other group, on heart failure cardiogenic shock. And I think that, ultimately we need a similar model or a similar protocol in heart failure shock to be able to provide best practices and try to improve outcomes for these patients as well. But differentiating the two was something that was really important within the shock initiative. And then using Swan-Ganz catheters and objective measures to be able to direct care, whether that's point of care lactate or even laboratory values, using invasive hemodynamics. It doesn't always have to be a PA catheter. Clearly, that's something that's preferred many a times, but even having a triple lumen in the right IJ, being able to calculate a crude FIC and a CVP can potentially really help you in terms of making decisions. And I think in resource scarce environments, I think it is really important to kind of keep those things in mind, that you can use all of these tools to be able to get information. But the most important thing is you do want some objective data to be able to help guide that decision making, because what the objective data does, it allows you, for example, to identify right ventricular failure, and that's something that is commonly forgotten. In NCSI, for example, 30% of patients had right ventricular failure, and they had worse outcomes. They had worse mortality. Yet right ventricular dysfunction was very scarcely treated with right ventricular support devices, right? We had a very, very high threshold of using RV support devices, even though their complication rates are much, much less because they're venous access, right? But regardless to say, the ability to identify and treat that was a lot less. And it is important to mention out that most of RV failure doesn't even need right ventricular support devices, but regardless to say, it was extremely rarely used in NCSI. And then I think what happens when you create these teams and protocols is you get expertise with all forms of devices, right? I still am a big believer in the use of balloon pump, but I use balloon pump in heart failure shock. I think Impella is now by far the gold standard for support devices. In AMI shock, that means an Impella CP. And I personally think in more advanced heart failure shock, that means an Impella 5.5. And I think that ECMO is always going to be needed, but it's probably going to be needed more in cardiac arrest and as an escalation tool in those settings as well. And so I alluded to this earlier. What we've done at Henry Ford is we've actually had an ECMO model that's included our cardiology division. So this includes critical care cardiology, interventional cardiology, and advanced heart failure cardiology. And so 91% of our patients in the last 5 years have been cannulated by an interventional cardiologist. They're managed on the cardiology service about 85% of the time, and the other 15% by the surgical service. And even decannulations are performed 75% of the times percutaneously. And so we've had, a good amount of success being able to give that option to our patients. And what I think in particular does is it decreases the delay of getting escalation for select patients. But ECMO in general is associated with lots of complications. And so it is really, really important that you use it judiciously when actually needed. And if you think about, you guys used a lot of ECMO here, what do you think about that as it relates to ECLS shock? Well, as I mentioned earlier, I think ECLS shock is not really the standard practice that we're using here. In fact, in our institution, only 7% of these patients would have qualified for the ECLS shock trial. And so in the United States, ECMO is really much more of an escalation tool than a standard first line MCS for cardiogenic shock, maybe for cardiac arrest, but definitely not for cardiogenic shock. And so where does that leave us? That leaves us with an ultimate task, right? And you all are in the same boat as we are here, which is that you're creating an amazing system, a system that is going to, basically take care of your entire province and be the center and the leaders of cardiogenic shock care. And what that means is helping those smaller sites that are referring into you do what they can to stabilize the patients so that they are able to expedite transfer to your facility to be able to get the best outcomes for these patients. And the thing that I'm most proud of the cardiogenic shock initiative is not just that we replicated the results of DanGer, but what I'm most proud of is we did it in the majority of community-based programs. These are the centers that are taking care of STEMI patients in the United States. And so we're spreading this information now throughout the country and throughout the world. And I think that really NCSI functions as the playbook for, DanGer shock. So where are we with NCSI now? It's the same protocol that we've used. You activate the cath lab, you get femoral access, you confirm AMI cardiogenic shock, you treat with MCS, then you do revascularization, you put a Swan-Ganz catheter in place, and then you decide, are you able to wean vasopressors and inotropes? Do you need to escalate support in 10 to 20% of patients? Those are all things to consider and hopefully be able to get better outcomes for these patients. And what we're doing in the ceramics trial, which is what we're doing right now, is we're looking at outcomes in patients who present to these shock centers. So we have 20 shock centers, and we're looking at same outcomes as NCSI, but within these 20 shock centers. And there's already a signal that there's much more escalation occurring within these institutions. And so we'll hopefully be able to share that in the next year or so. So in conclusion, the DanGer shock trial is a landmark trial. It's a guideline-changing study which demonstrates the benefits of the routine use of Impella and AMI cardiogenic shock. There are important differences in the randomized control trials to date. Hopefully, I've explained that a little bit more, but I'm happy to discuss it with you all more. But I think where we are in terms of contemporary management is that there are 5 pillars of treating shock: early identification and treatment, differentiating AMI versus heart failure shock and cardiac arrest shock, using objective measures to guide care, getting expertise in all devices, creating a hub and spoke model that emphasizes this community care model. But despite these advances, there's still a morbidity and mortality associated with this. We still need better complication management, better heart failure outpatient follow-up for these patients, but I'm very confident that we can do that, particularly on the heels of DanGer shock. So that's it for my presentation. I'll stop sharing my screen, and I'm more than happy to stay on and discuss with you all. Thank you again so much for having me.
So, thank you, Babar. Thank you. It's a great session you just gave us about DanGer shock and NCSI and the current state of shock at your institution. And I'm happy to have also Dr. Guillermo Torre. She's right here next to me.
He's the rector of Tech Salud, and he's also a cardiologist specializing in advanced heart failure and transplant. So, Doctor, if you want to make a comment, please.
So, Robert, thanks. A terrific lecture. I think the major problem in Mexico is that there will be very few patients that have access to PCI sites for acute MI, and even less sites that will be capable of doing complex mechanical support. So I guess the question that, and this applies also to the US, to the larger number of centers that may not be capable, that maybe a PCI sites, but they won't be able to have a cardiogenic shock team that will be able to do advanced therapies, advanced mechanical support. So really putting that in context, the question I would have is, are you trying to ask the question or answer the question, how can we help people that go to a site where they can perform acute revascularization mechanically? And then the question is, should they later be transferred to a site for continuation of mechanical support for a period of time? What would those patients be? Is it possible to do a study like that? Because I think once you go to a Henry Ford, you go to Methodist Hospital, or you go to Brigham, or you go to big sites, I think nobody would question the strategy. But I think the larger number of patients are not going to come to sites capable of. And then the question is, would be a reasonable strategy to do an acute intervention within some parameters of shock, still refer to a higher level of care for a more elective mechanical support to obtain the subsequent benefits of unloading and preventing further progression of disease and organ injury and so forth. So it's sort of a theoretical question, because I think listening to your conversation, and there are others here from Mexico, I'm not sure that we are capable in the country to do this in maybe more than 10, 15 sites across the country. And then the question is, how would you develop then a strategy that would be applicable to the larger number of patients here, as well as in the non-shock centers in the US? So maybe I'll stop here. Again, thank you for your time and the terrific lecture, but maybe would love to hear your thoughts on this field and this topic.
Yeah, it's actually a brilliant question, and I think it's really very challenging to answer, and that's because there's lots of different. There will be an evolution that comes in post DanGer, and what we're blessed with is that we've had a very similar process with STEMI, just in general, STEMI systems of care, where it started off in these unique centers. I get to work with Bill O'Neill, as many of you know. I get to hear the stories about how a primary angioplasty originally started, the criticisms that were faced because of the higher complications, particularly when they did PCI on top of TPA, and then the slow evolution of getting more and more cath lab centers, at least within the United States, so that now about 75 to 80% of Americans can get revascularization mechanically with PCI as opposed to getting lytics. But even in the United States, it's still 15 to 20% of patients still getting lytics, right? And when we think about this at the international level, it's not surprising that it's maybe impossible for many institutions not to be able to offer these therapies. I'm personally from Pakistan, and I don't even, there's no reason for me to even talk about this in Pakistan. I mean, if you have a shock, you're probably going to die, and that's it. And that's unfortunately the circumstances that we're in. What I think is important, though, is for all of us to appreciate the fact that these technologies offer that benefit. And in select patients, identifying that early, and as you said, transferring the patient early because of the potential need and the option is something that's really, really important. And I think you have to be 2 steps ahead in resource scarce environments, as opposed to here. What happens in the United States, or maybe just in Detroit, is that these patients have a complication, then they get transferred, right? And you know, then it becomes a whole mess for lots of people. But being able to predict that, that's where, you know, maybe right heart cath numbers are very valuable. You know, trying to do as much as you can to prevent the shock from getting there. But I totally agree with the sentiment. I think that right now, in resource scarce environments, what we're talking about is having a high threshold or a high understanding of identifying these patients early and transferring them early. I hope I answered that at least the best I could.
Yeah, no, I mean, I think it's a very important question, because I think you're speaking mainly to people in Mexico today. And then the question is, what are the capabilities of the sites of the people in here? And we probably, where we are, we have the ability to do that, but we recognize that there are very few sites in Mexico that have that capability. And I think when you see the evolution of thrombolytic therapy and PCI for acute MI, it's exactly what you said. People, in fact, I will give you a background in the history. When I was a cardiology fellow in Houston, we would fly to give thrombolytic therapy. People did not give thrombolytic therapy on site. We would go to the different regional hospitals and initiate therapy. Doctors at the site were not trained. They didn't have I guess that training, and at that time thrombolytic therapy was a big deal. So that happened. But then of course people become more familiar, same with PCI. So I think, and I wanted to push you to the concept that perhaps at some point in places like ours, developing teams that can go to the site and maybe following the acute intervention, then the team comes in and then provides additional support. And people do that in Europe. There are, you know, a number of sites in the US that go to places and do ECMO on site. And so I think that at some point, maybe with more maturation of the strategy, then that will be a next step, right? Once it becomes universally accepted, as we hear you, of course, the data is very convincing, but whether or not that will permeate, but then at some point, I think that will be a very important addition, particularly to make it more democratic, to make it more available to others. But
Absolutely. That's fantastic. Sorry.
No, I'll send it to some others in the.
I think we have a couple of questions from the audience. So this is we have Dr. Erasmo de la Peña, which is the chief cardiologist from here from our institution. Erasmo, do you want to comment or make?
Yes. Thank you, Babar. Thank you very much for sharing your knowledge with us. I do have a question for you. What would you be? I mean, we know and we are learning more every day about shock, and however the treatment varies a lot, and it's depending a lot on resources. So you mentioned about stabilization, but do you foresee a future in which you will be standardizing the care of the patients out of the centers that have or that offer a high level of treatment, like assist devices, particular assist devices, in which you are planning to manage to a certain point and then trigger the fact that you need to refer that patient at that moment?
Yeah, no, I think it's going to be center by center discussion on that regard, right? But I think protocolizing the early level care, what the institution is capable of doing, and then potentially escalating to those institutions that have the full escalation capability is really important. So in the state of Michigan, for example, there are 3 advanced heart failure transplant centers, right? But there's lots of centers that can provide Impella and ECMO and other support devices here. So, you know, you can probably take care of the vast majority of patients in those centers and only reserve transfer for the advanced heart failure transplant patients if needed. So I think it's going to be very institution specific, but yeah, I totally agree with the sentiment.
So we also have Dr. Jan Manuel Jimenez from the Instituto Nacional de Cardiología in Mexico City. He's also an expert in MCS there in Mexico City.
Thank you, Vicente. Thank you for having me and for the time. It's a pleasure to hear you, Dr. Babar. I was wondering if you can elaborate more about the, sorry, I'm just arriving. to my office. I was wondering if, Babar, what's your opinion about the necessity of more support? I mean, if you are under the idea that we need to go for an Impella 5.5 or wait for the new device, this expandable Impella that Abiomed is going forward. So do you think that we must keep going for a better support or a stronger support, or we just have to keep working on Impella CP? Thank you. Thank you very much.
No, it's a really good question. I think in shock, you need more support. And even though I think CP was extremely helpful, I think future iterations will make this even easier. So an ECP, as you mentioned, is a self-expanding pump. It is, goes in through a 9 French sheath. There's also a company called Magenta that is making a device that is over 5 liters of flow using a 10 French sheath. So the future of small bore MCS devices is definitely forthcoming. What is important is that unlike high-risk PCI, where you just need the device for 3 or 4 hours at most, right? You using it in shock for a few days is different. So the durability of these self-expanding pumps and how well they do, that is what we really need to test. And it's actively going on. I mean, these devices are going to be tested within the next 5 years to a level that I'm very positive and comfortable saying that is the future direction that we're going to go in. And hopefully at some point it will translate into decreasing cost. And that, I think, will help permeate the ability of other centers and other countries and other institutions to being able to get these devices. So that's definitely my belief, is that we still need more support, but we need to, worry about making it smaller and easier to deliver. And there's some nuances to this. I've used the ECP quite a bit. I don't think it's ready for a shock cases as of today, but I'm very confident that it will be in the future. So.
And my question was going to go there, actually. We have the DanGer, finally, the results of the DanGer shock, which is the in many years, the first positive trial for shock. So everyone was very excited about this. And there are many strengths about this study, like they had an escalation protocol. Because I think what we've learned from different trials is that you have to, we don't need to know like which device is better, which is important, but also to have an algorithm, to have protocols, to have a shock team-based approach. And that's what has shown to improve survival in these patients. So I wanted to ask you about the adverse events in DanGer shock. So where is this looking forward to? We getting better devices, better technology? Are we getting because many of the adverse events occurred not in the cath lab, because we as interventionalists, we finished the case and we think it's victory, but then the patient goes to the ICU and there's where the complications occur. So it's just not, we have to reinforce or train the personnel, the nurses, the staff in the ICU for these devices, because the adverse events are occurring there mostly, I think. What's your opinion on that?
Absolutely. No, 100%. And the thing is that it's one aspect of it is training. One aspect of it is technological advancements and making things smaller to deliver and those kinds of things. But it is just really, really important to keep working on it. And what that means is trying to get better over time, right? So I think leg immobilizers help decrease complications. I think keeping the anticoagulation levels low, your anti-10A or your PTT lower is better. With Impella in particular, I don't think you get a lot of thrombosis, but I think it's just important to kind of keep that in mind. Pre-PER closing is important. Hopefully this whole Impella peel away sheath goes away and we just get one standard sheath that we never have to peel away. When it comes to ECMO, commonly using reperfusion sheaths is important. I think all of these things, I think we're really at the beginning of improving care, but I think what was necessary was to have DanGer shock so that people knew ultimately we were saving lives. And now, as we decrease those complication rates, the amount of benefit from the support devices becomes even more.
Okay, great. And just your final opinion on Recover 4, recommendation of termination of the trial. We were all expecting these results because we think DanGer shock hasn't answered all the questions that we have about shock. So we thought maybe Recover 4 was going to give us more information about how to treat these patients. So your opinion on this?
Yeah, so it's final, 100%. It's not happening, at least standard of care versus Impella, because I think Impella now is the standard of care, at least in the United States and Europe. And I think that definitely lots of questions to still be answered. But subjecting patients to not having support device, I think, is very problematic. And so I think what's going to happen going forward is a different trial. It's probably going to be using devices either in a standard of care or with a host of best practices, or looking at multi-vessel disease versus culprit PCI versus non-culprit PCI, because clearly that's going to be slightly different within this patient population, or with Impella as opposed to ECMO. I don't know what they're going to kind of finally settle at for what the plans for Recover 4 will be, or what the new name of the trial will be. But at the end of the day, I think we still have lots to answer. The most important one may be that heart failure shock, right? It is more than the AMI shock that we see. And what's the strategy for those patients? So lots of work to be done. So hopefully all of us can collaborate, get together, and do that. For those of you who do have Impella available to you, we are literally going to be starting an international shock initiative, we hope, at the end of this year. And so we would really, be, happy to collaborate on that.
For sure, we're very interested in this. So I would like to thank everyone for your attention. Thank you, Babar, for this great lecture. And also I want to remember that we're having our second annual Cardiogenic Shock and Heart Failure Latin American Symposium in Cancun in October. We're having also Dr. Bill O'Neill and Dr. Babar Basir there. So we're gonna have a great time there, and we're gonna learn a lot from you guys. So thank you very much, and we'll keep in touch.
Wonderful to see you all. Take care.
Thank you.